So let me welcome you. My name is Kim Burton. I am from the Mental Health Association of Maryland, and I'm really grateful to be participating today to talk about late life issues. So I'm the senior advisor to older adult programs for the Mental Health Association of Maryland, and I've been doing education around aging and behavioral health issues, including trauma, for several decades, actually. So I want to start out with some goals that I have for what we're going to talking about today. And I'm hoping that you walk away with this kind of an understanding, but this also lays out kind of the agenda of the talk today. So I'm hopeful that you leave with an understanding of the impact of early trauma experiences on later life, the traumatic impact of common late life experiences, themes of late life challenges and risk of compounded stressors that are more common in later life. Also, latent trauma triggers, re-traumatization, and reasons that trauma may not be revealed among this population. Also, hoping that you understand some of the risks to older adults who are experiencing trauma, the trauma-informed approach and associated care principles, strategies, very important, and what we can do to support older adults. Talk a little bit about dimensions of recovery, and then go through some supportive resources, and hopefully have time at the end for some Q&A. I'd like to start out with a definition by SAMHSA, which is the Substance Abuse and Mental Health Services Administration. They do the dominant work here in the United States on trauma issues. So they say individual trauma results from an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has a lasting adverse effect on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So you can see here that the definition that I have is really about individual trauma, but I want everybody to bear in mind that trauma can come in many forms. There's community trauma, there's intergenerational trauma. So for today's purposes, it's really critical that families and communities and systems of care are sensitive to the resurgence of thoughts and feelings and beliefs and behaviors that are associated with cultural trauma and historical trauma as well. But I am going to be focusing mostly on the individual. So just as a background for those of you who aren't familiar with adverse childhood experiences, and many of us are, but I have to tell you that many older adults are not. I do a lot of education to older adults, and they're just not necessarily in sync with this kind of information unless it's a field that they're interested in or that they may have worked in. So as you may know, adverse childhood experiences fall into different categories. And so there's physical, emotional, or sexual abuse, there's physical or emotional neglect, and then several issues having to do with household dysfunction that were found in a huge study of more than 17,000 people back in the early 2000s. And what they found was that people who have significant adverse childhood experiences that fall into these categories actually have a one-to-one dose effect with certain health outcomes. So what does that mean? That means the higher the number of adverse childhood experiences that a person may have, the more likely they are to suffer from certain health consequences. So for example, people who have a score of 4 ACEs or more, and so really it's like if you experience 4 of these things, you are 2.5 times more likely to develop COPD or hepatitis, 4.5 times more likely to develop depression, and you're at a 12 times higher risk for suicidality, which means suicide, planning for suicide, or actually making a suicide attempt. People with 7 or more ACEs are at 3 times higher risk for lung cancer and also for heart disease, which is the #1 killer in the United States. And I put down here in the bottom right-hand corner These are two websites that I would recommend you visit to understand a lot more about ACEs. When I first developed an understanding of ACEs and what they were and the impact, I have to say for myself, I was really distressed because I have a very high ACE score, but I don't want people to walk away with thinking that if these are experiences that you've had in your early childhood or other people have had in their early childhood, that means that they're on, a downhill trajectory and that they won't live a great life. It really is more about understanding the health impact. And I don't want to walk far down that road. I'm going to get ahead of myself if I do. So in 2019, in the publication, the Journal of the American Geriatric Society, they were looking at the linkage of adverse childhood experiences to psychiatric disorders and substance use disorders in people over the age of 65. And they extrapolated from that to come up with a estimated national prevalence. So of the 14.8 million older adults nationwide at that time, 35.9% experienced an adverse childhood experience. So overall, that's the experience. And then you can see how it's broken down into certain percentages based on people reporting if it had been neglect or abuse of particular kinds. Parental psychopathology means growing up in a household where there was mental illness or substance abuse or domestic violence. So that's what that category means right there. So having experienced any adverse childhood experience associated with a higher odds of having a psychiatric or substance use disorder in the past year. Here's another way to look at this. So this is a pyramid that represents how adverse childhood experiences influence health and quality of life. And so this is what we're talking about today. And if you look from the bottom up, from literally birth up through death, you can see how adverse childhood experiences has this momentum that influences certain adverse issues having to do with health, social issues, emotional issues, and see the red bar there, disrupted neurodevelopment. So this is really the key here. When people are experiencing big stress, we have physiological mechanisms in our body that really there are lots of conditions that are happening in the body. I'm trying to figure out how to make it the most simple. And I think the best way to say it is that our stress response, our fight, flight, freeze response, brings up cortisol and other hormones and stress in our body that is actually toxic to a number of our different organs. But it also inhibits our ability to access the frontal lobe mechanisms of our brain. So essentially, the more we live in fear, the harder it is for our brain to develop the healthy way that it needs to be able to learn, to be able to make decisions, and so forth. So people who have experienced a number of adverse childhood experiences have actually a 20-year difference in their life expectancy. So today we're talking about older adults, and they may not be chronologically older, but individuals who have experienced these kinds of traumatic experiences or adverse life experiences may be geriatric-like at a younger age, meaning they might have comorbid conditions, health conditions, and so forth, that make them less healthy at a younger age and actually reduces their life expectancy. So there's something called accelerated aging. And I'm going to read about the term of accelerated aging. It's used to describe how post-traumatic stress disorder may manifest differently in older adults relating to issues in attention, memory, and executive function, elevated stress hormones, and changes to the brain structure. These occur more extensively in older adults coping with trauma. Often the effects of trauma or accumulated traumas express themselves in behaviors such as agitation, disorganization, self-neglect, and this may be seen as normative cognitive decline. It might also be seen as symptoms of other health conditions or medications that people might take. So essentially, older adults who are experiencing these cognitive impact of trauma might be labeled. All right. We often label the behaviors. I used to work in a nursing home, and I regret some of the things that I did back then or thought back then, but it was common for us to label a nursing home resident as combative if they were swinging at somebody when somebody was trying to provide them personal care. Looking back and knowing the likelihood of the trigger of somebody coming into the room of a nursing home resident to take off their clothes, to bathe them, to take them to the bathroom, I now understand they weren't being combative. They were very threatened, potentially felt very threatened, likely felt very threatened, and were just trying to protect themselves. We might also label somebody as being an introvert, when in fact, if they've experienced trauma, they may not feel comfortable in groups of people. We might label somebody as being aggressive, again, when they are just trying to protect themselves. So this is something we need to be really keyed into with regards to older adults. And I want you to see the reference at the bottom, trauma-informed approach for adult protective services. I myself don't work in adult protective services, but I found this resource to be one of the best that I've ever read about trauma. So I would encourage you to take a look at that. So let's think about some reasons why older adults may not reveal trauma. There are multiple reasons for this, and reading from the top left across, first of all is the culture of older adults, often raised at a time when they didn't talk about things that happened that were unpleasant. They didn't share family secrets. These are not necessarily a group of people who were cultured to talk about things that happened. So that's one reason that trauma may not be revealed. Another is that they may not have thought of their experiences as traumatic. If they were beaten as a child, but everybody was beaten as a child, they may have seen that as normal, right? So they wouldn't consider it to be trauma. Other reasons are feelings of shame or guilt or self-blame, or they don't want to talk about things that have happened because they don't want to open old wounds. That's a very common reason. I hear from older adults about why they don't want to go into therapy. So that's one thing I want to just say right here, I guess, is that when we're talking to somebody about therapy, let them know that therapy doesn't have to mean opening old wounds, that there are many other kinds of therapies that don't involve them going back and rehashing things in the past that they'd rather not think about or look at. Another reason is fear of judgment. There is also the loss of confidence and support network. So what does that mean? That means that if they don't have their same friend group, or they've lost family members or a spouse that they would normally talk about these things with, then that might be a reason that they're not going to be talking about it. And then a big one is the concern for legacy. So it's really important for older adults to feel that they have the respect and dignity of the younger people that have come behind them in their family or in their other groups. And so it can make them feel a little bit worried about the kind of legacy they would leave if they start to talk about things that they're not comfortable talking about. So right now, I want you to take just a couple minutes, and maybe you can put this in the chat. I am having a little bit of a problem kind of seeing what you all are doing, but I'm going to try and take a look. I would love it if you would put into the chat some common late life challenges in these categories of physical, emotional, social, functional, and mental. What are some of the challenges or the changes that could be experienced as traumatic? And I want to allow for the fact that people have all different kinds of responses to different changes and challenges as they grow old. So I'm not trying to stereotype, but I am trying to dig down and have you think about those kinds of changes that people might experience as traumatic. I'll put my notes over here and see if I can open the chat for a minute. And I don't see how I can do that. Sorry about that. Hopefully you're thinking about different kinds of issues. I'll give you some examples in the different categories. So physical changes might be loss of vision or loss of hearing, changes in senses. I just figured out how I can look at the chat. So Laurel offered that physical pain, absolutely. Physical pain is huge. And some of these things that we're talking about, these changes and challenges, pain is one of the primary ones, are also very high risk factors for the development of late life mental health problems. So anxiety and depression are our most common late life mental health disorders. And they often arise from things like pain, from changes in sensory experiences. So low vision, low hearing, emotionally and mentally, the loss of loved ones, maybe to death, but also older people sometimes move, right? So if they move from a place that they've been for 50 or 60 years, there's a whole cascade of changes that also represent loss. So I'm going to close the chat on my end now, and I'm gonna go to the next slide. And here, what I'd like to do, I don't know how I put that yellow mark on there. Isn't that interesting? These are perhaps some of the late life experiences that you were thinking about from that last slide. Changes and challenges that tend to be either experienced as trauma, or they can trigger past trauma. And these are very, very common experiences for older adults, and they make sense here. I'd like to pull out in this particular slide isolation and loneliness, and I'd like to do that because of COVID-19. Older adults, as you know, are very vulnerable to the health problems that come with COVID-19 and the risk of death that comes with COVID-19. So we are looking at a population of people that are more likely to stay inside or stay away from other people, and may not be engaging in activities that they love or being with the people who keep them vibrant and happy. So right now, we would have to say that the isolation and loneliness is extremely problematic among most older adults. What I want to do with this next slide here, looks like I'm going to have this yellow thing on all the slides, and I apologize for that. I'm going to talk a little bit about like the compounded trauma. So I'm going to use an example here of this man who I've named Gerald, who's 70 years old. And Gerald had a fall in my story about him, and he broke his hip, which is unfortunately a common break among older adults. So as we get older, one of the physical changes is our bone density and strength, and we're more prone to breaks when we fall. And that would result in a hospitalization. When an older adult is in the hospital, especially if they have surgery, they're more prone to delirium, which is a pretty significant psychiatric issue that is caused by something that's happening in the body. And for older adults, that can happen easily with anesthesia, with multiple medications, a number of reasons. But it's also hard to be in a hospital and recover. As you may know, things are dinging and bells are ringing and people are coming in. And so it's then challenging to get a good night's sleep. And all of these things, these issues start to kind of compound. If you think about Gerald here at the age of 70, having fallen and broken a hip, and let's say he's in the same room with another young person who's in their 30s, who also fell down and broke a bone. If you think about it, their experiences in inside their head, what's happening inside their head could be extremely different. Usually with a 30-year-old, we are anticipating easy rehabilitation. That 30-year-old may be thinking that they're going to be up and running in a marathon again next year. But not so with older adults who then begin to wonder, am I going to be safe in my home now? Am I going to be able to go home? What if they have the only bathroom in the house is upstairs? So these are the kinds of things that may start ticking around in their head, causing a lot of distress and threat. So one of the things that we need to really think about with older adults and with these kinds of changes that we're talking about are the themes. And so here are some of the themes of late life changes and challenges. Themes of loss, disempowerment, risk, and things that are unwanted. So Gerald didn't want this to happen. Gerald is now disempowered, right? He is concerned about the other things that he might lose as a result of his need to be in a nursing home. Is he going to be able to go home? And risks can elevate from there. So I now know that it's not me making these yellow lines. I'm going to try to ignore that. Anyway, what we need to bear in mind is that most, unfortunately, many of the changes that older adults are going through are things that they didn't necessarily choose. They're oftentimes things that represent loss, things that they didn't want to have happen to them, things that may risk their autonomy and their ability to live out the rest of their life the way that they would want to. And these changes are so common that we should really expect and plan for distress, but that's not really the approach that we take. Often in our health and human service sectors, what we're doing is we're waiting for somebody to show signs of distress instead of anticipating it. And I would advocate that we should be anticipating that there is going to be distress, that older adults will be experiencing trauma. We can't see it on the outside, but there are certain things that we can do on the inside that we'll talk about in a minute here. So not sure if I have, if I'm talking to a group of folks that already know about Maslow's hierarchy of needs, but this is Maslow's hierarchy of needs, often embraced as a model of development whereby as we grow older, we make our way up this pyramid. The more we feel secure in our lives as children, the more likely we are to be able to develop relationships that are healthy, to go on and learn things that we want to learn and pursue careers and interests that we want to pursue. And ultimately, what we're all wanting to do and what we should hope for ourselves and each other and for older adults is to be able to remain at optimal functioning, you know, doing the things that we love to do and having the quality of life that we want to have. And you can go to any card store and look at birthday cards, and they will talk about aging as a downhill experience. And aging is not a downhill experience. Most older adults report that it's a time of great satisfaction for them. But it is a risky time, as we've been talking. So instead of looking at aging as a downhill experience, I think that we should look at it as a risky experience, and that things that can happen that kind of poke holes into these different areas that are just so important for us to maintain our optimal function. So if you think about Gerald again, our 70-year-old who's now in a nursing home because of his hip fracture, and he's getting rehabilitation. But just think about what his experience might be if he has been a top manager in a company that he works for. And that's what he does Monday through Friday. He's a manager. Saturdays and Sundays, he enjoys fishing with his friends. And so if you think about the kinds of things that he may not be able to do right now, and maybe for a long time, you can see how we've poked some holes here in the kinds of things that Gerald needs in his life in order to have the quality of life that we would expect. Unfortunately, I think in our society, we just too often look at people who are experiencing those kinds of changes and looking at it as a decline from which they won't recover. But people recover all the time. You can imagine, though, in their heads, they might be thinking along with the stereotypes of like, oh, here it comes and my life is going downhill. So I think one of the most important things that we can do is to help provide hope for people. So let's talk a little bit about what the impact is of trauma on later life. So these bullet points are little brief bullet points I want to expand on a little bit more. The first is ineffective coping, and I have that in quotes because we might say that a person is not effectively coping when in fact they are having a normal response, that a trauma response that they would have that may look like cognitive impairment. It may look like a mental illness or a substance use disorder. Again, if their behavior is in accordance to their experience of trauma, so they are experiencing distress, we might be quick to label them and say that they're not coping very well, when in fact we're not thinking about the compounded trauma and that their response might be perfectly appropriate to the situation. Another problem that we see is that people may refuse to participate in healthcare. So they may not want screening or assessment or treatment. And I see this most often, well, in my experience when I was working in a nursing home, where I saw this most often was among women who had likely experienced sexual abuse. And so they weren't comfortable with the whole process of going to a doctor, having to take their clothes off, especially with gynecological exams or breast exams. That was something that they wanted to avoid. So we do see people who are avoiding necessary things that they need later in life to be able to identify an emerging health problem. So another thing that we might see impact-wise is fear. I think I mentioned fear of being in settings with like congregate settings. So if I'm a person who experienced trauma in my past, I may go into unknown situations with certain level of fear. I don't know what's going to happen here. I don't really know what to expect. I'm not sure I'm going to feel safe. And so we see a higher level of fear among older adults who have experienced trauma, and that only makes sense. Another thing that we see are an exaggeration of triggers. And here I'm talking about in relationship to cognitive impairment. A lot of older adults experience cognitive impairment, and that is kind of a lighter way of talking about dementia. So cognitive function is a spectrum, right? So let's just say on this end, we have people who have optimal cognitive function, and on this end, we have people with severe dementia. And as people get older, we see some cognitive changes that don't impact people's intelligence or their ability to engage in life, but things might slow down a little bit, might be take a little bit longer for recall. People might need to make notes to remember some things. Perfectly fine, perfectly normal, not to be worried about. But then there is an experience called subjective cognitive decline or mild cognitive impairment. MCI is how the term that many people use. And that means that the individual is experiencing cognitive changes that they notice and maybe people close to them notice, but that isn't really noticeable to other people. And when individuals start to feel this way, if they are in conversations with people and they forget the words that they want to use, they're forgetting names, what we start to see is people who start to withdraw, who really don't want to go out and do things socially the way they may have before because of feelings of shame or embarrassment. And so look at that kind of word that I just said, shame. The feeling of shame that I might have around mild cognitive impairment might be a trigger for shame that I had felt in the past when maybe I was bullied for being stupid. So what we see is when those little emotions or those thoughts or feelings are triggered, that people might later in life, decades later, start to have stress responses, even if they're not appearing to be stressed from those looking on from the outside. So when people have cognitive impairment, and I talked about mild cognitive impairment, some people go on to develop dementia. Dementia, I just want to say, is not a diagnosis in and of itself. Dementia is caused by something. So if somebody has dementia, something is causing it. And the number one cause of dementia that we don't have a cure for right now is Alzheimer's disease. And so somebody with Alzheimer's disease or vascular disease or another kind of disease that causes dementia, the dementia can get worse. The reason this is important when we talk about trauma is when people have dementia, then this frontal part of their brain that is responsible for controlling their mood and their behavior, and also really key to self-regulation, this part of the brain may not be working so well. So that means if the fear arises in somebody because there is some kind of a trigger in the environment that brings up fear, they may not have the cognitive capacity to look around and say, oh, I'm okay. So for example, if we hear a car backfire and we all have kind of that feeling of what just happened, you know, all of us have that stress response. If our brain is working the way that we hope it would be, we can look out the window and say, oh, that was a car, no problem. But somebody who has dementia may not be able to do that. So you can see that they wouldn't be able to calm themselves down from a trauma response that they're having. So two other things that are pretty important to mention in terms of the impact of trauma in later life is the likelihood that a person will experience elder abuse or be victims in other ways. So maybe a victim of a scam, maybe victim just by nature. I'm thinking right now about a gentleman I know who I worked with who had a history of trauma, who was older, and he had family members that were living with him that were using all of his resources. They were eating his food, they were using his toothpaste, everything that he bought for himself were being used by other people, yet he didn't have the money to be able to do that. And so in a way he was being taken advantage of, but he didn't, I feel like I'm putting the blame on him by saying he didn't. Let's just say the circumstances were that he was a victim. So polyvictimization means that victimization that can come in many different forms or that can happen in many different ways. All right, let's go on to the next one. Ooh, you can really see the yellow now. So here are some risks to older adults who are experiencing trauma. This is what we see when older adults are experiencing trauma. We see a greater likelihood that they will withdraw or isolate, and that can lead to loneliness, which can lead to all kinds of physical and mental health problems. We see the emergence of, or the beginning of, or the worsening of substance use disorders. Same with mental health disorders. Cognitive impairment is also an outcome of, not an outcome. People who have experienced trauma have a higher risk for experiencing cognitive impairment of the kind that I have already talked about. They're also at higher risk for experiencing health problems, and that goes right along with the triangle that I was showing you earlier among the ACEs. So people being more likely to have heart disease, lung disease, kidney disease, liver disease, etc. We also see functional decline. So people who are less mobile, maybe less able to take care of themselves in ways that they need to. That's what we mean by functional decline. Relationship problems, certainly. And unfortunately, we see premature or unnecessary institutionalization. And that might be in a hospital, that might be in assisted living or in a nursing home. And unfortunately, as I talked about earlier, people who have experienced trauma tend to have earlier death than people who haven't experienced trauma. So let's go now to talking about trauma-informed. And what does a trauma-informed approach mean? So what I would like to say about trauma-informed before we go into the different points on the slide is that this isn't easy stuff. Trauma is not obvious. It's not a wound that we can put a Band-Aid on and know that we're taking care of it. So some of these things might seem a little bit amorphous, but I also find them to be really encouraging because we don't need to sweep trauma under the rug. We just need to know how to work with people who have been traumatized so that we can make things easier for them, bring them better quality of life. So here are some of the things that it means to be trauma informed. And the first one is this flip of the script. So the mentality of what happened to somebody. Sometimes when people behave in distressing ways, we might say, what's wrong with you? You know, when a kid misbehaves, we might say, what's wrong with you? And that internalizes to a person, oh, there's something wrong with me. And with people who have experienced trauma, what the question should be is what happened to you? Because what happened to them then brings about the result of the behavior that's happening now. So it's not what's wrong with you, it's what happened to you. Very, very, very different question, and elicits a different kind of response from people. Being trauma informed means that we understand that there's a cumulative impact of trauma. So that means the more kinds of experiences that people have of trauma, or the length of time over which trauma is perpetuated is significant. And that people who have behavioral challenges often have roots of their behavior that go into their trauma experiences. So what we want to do in terms of being trauma informed is really promote an approach that is healing. And we do that in a couple of really important ways. We look at people holistically. So we understand, for example, if somebody is working in a doctor's office and they are working with somebody who's experienced trauma and they're having health problems, they need to be holistic and not just talk to that person about, here's the medication that you need to take. They need to understand that maybe that person needs some assistance with getting food, with knowing and developing healthier habits. So that's what I mean by holistic. We also want to be strengths-based. So we all have strengths, and we need to promote the strengths within an individual, acknowledge the strengths within an individual. And this leads to some ideas and thoughts around what we can be doing to help them with supporting themselves. Okay, so we're not going to be treating people as victims as much as saying, you know, we have faith, we believe in you, and we know that things can get better. And so let's look at the things that you do well, and let's build upon that. The other key things that are really important is making sure that an individual feels safe and in control. So thinking back again to some of the disempowerment where people were feeling threatened, they were feeling that they weren't in control. This is a way for us to give them what they need so that they can best work with us, best work for themselves. So this next slide is a little bit redundant, but so if this is about a trauma-informed approach, these are the trauma-informed care principles. And this, by the way, is all easily found at the website for SAMHSA, which you can see across the bottom, Substance Abuse and Mental Health Services Administration. The H should be capitalized, sorry about that. But these are the principles that they recommend to organizations. So we're trying to infuse these principles in systems of care, healthcare, human services. So not only systems and organizations, but also the professionals, the people who are working with individuals who've been experiencing trauma. These are certain components that we know are necessary to best support individuals who've experienced trauma. And if you have questions about what some of these mean, We can talk about that in our Q&A at the end, but you can also learn a lot about this. I just remembered I have the report. So SAMHSA put out a paper in 2014, hoping you can see this. SAMHSA's concept of trauma and guidance for a trauma-informed approach. And this is a really robust document that has a lot of recommendations and suggestions, and also ways that people can do an assessment of their organizations or of themselves, and not so much, but can help with people trying to figure out how they as an individual can be trauma informed in the way that they're working with or approaching anybody. It doesn't have to be an older adult, but really anybody. Ultimately, what we're trying to do, right, is support older adults. And when they are experiencing distress, if they are experiencing a mental health problem, for example, what we all aim to do is help them towards recovery. We want to help them in healing and in recovery. And the Substance Abuse and Mental Health Services Administration has developed some what they call dimensions of recovery. And here they are for you to read. And actually, I'll read them for you. So one dimension is health, overcoming or managing disease or conditions, making informed and healthy decisions in support of well-being. Another element is home, a safe and stable place to live. What we all would hope to have is purpose, so meaningful activities and the independence and resources to participate in those things that are meaningful to us, not only activities, but relationships. And they are community, so relationships and social networks for support, friendship, love, and hope. Hope being the most important. Hope is what I want you, what I hope you take away from today, if nothing else, is that we can really help people just by demonstrating that we have hope for them. We have hope for their healing and hope for their recovery. So these key elements, what I want you to think about right now is how these key elements are actually threatened by some of the challenges and changes that we've already reviewed that come along with aging. So let's think about Gerald for a minute. Here's Gerald in the nursing home. We want Gerald to know that he's, we're expecting for him to get back to the job, get back to fishing, get back to his home, right? He may be experiencing a lot of distress and perhaps depression, which would not be uncommon given all the changes and experiences that Gerald had recently had, right? So these are the kinds of things that we know will be most helpful to Gerald if we can have them in place. Yet all of these things are a little bit threatened right now, and really are dependent upon his healing, right? So one of the things that an older adult might do is internalize the stigma of aging, meaning, and I referenced this earlier, that they may not be thinking about getting better. They may be thinking about, oh, here comes the end. And so that's really where our work comes in terms of helping people to hold on to hope. And then to the best of our ability to work on these different elements and see that we can have them in place so that we can optimize the person's ability to get back to life the way that they want it to be. So what does this mean kind of at the individual level? Whether you're a professional or whether you're a neighbor or family member or friend, and you know that you are with somebody who is experiencing distress, as a result of trauma or another means of distress. These are things that all of us can do that can promote healing, things that we can do that are supportive. So I put this as messages that we want to give to people. And I don't mean that literally. I don't mean that as this is verbally what we want to say. We may say this verbally, but we also do these things non-verbally. These are actions. These are ways that we can engage with people that are most supportive when they are experiencing trauma. So the first is to really listen to what people are saying And so you may say verbally, I'm listening to you, I hear you, but you also need to make sure you're doing this non-verbally. So if you're on your phone, the message isn't that you are giving your full attention. And that's what people need. They feel dismissed if they're not getting your full attention. And that can really damage trust, does not help with relationship development. So another one is respect. And so the message that you're trying to send there is that, that you respect that people may not want to share everything with you, right? This could be challenging to people who are professionals, who have a list of questions that they are supposed to ask. They've got this check the box that you've answered or that you've asked these questions of somebody. Yet these are the kinds of questions that can really trigger people. So if those questions have to be asked, I recommend that you say up front, I have some questions that I need to ask of you, and I respect that you may not want to talk about some of these things, and that's okay. If you don't want to answer any of these questions, we can revisit them later. That takes enormous pressure off somebody who's feeling fearful. And when they're feeling fearful, by the way, remember that they're not able to best engage their frontal lobe. So if you are trying to do an interview, that interview is going to be compromised by people who are feeling scared at the time. Treating people with dignity, letting them know that they're not being judged, that you're there for them, that you care, and that you want to understand. And empower people. So there are some strategies coming up that are really important with regards to empowerment. But all of us are going to feel better about any plan moving forward if we are part of that plan, right? So that's what we need to do for people who have been disempowered by things that have happened to them. We don't want to be doing things to them. We want to be doing things either with them, but best way is to have them doing things for themselves with our support if necessary. So here are some good strategies for support. One is to make sure that people always know, if you're a professional, why you're engaging. What are you doing? People need to know what to expect. If they have had bad experiences because things that they have happened have been dangerous or unpleasant because they were unexpected, what we want to do is let them know what they can expect from any kind of engagement. We want to let people know that they're in charge, that they have agency over themselves. We can promote empowerment through education. And so one of the things that people are trying to do with regards to adverse childhood experiences is to put a positive spin on it. I don't mean spin something negative when it shouldn't be, but instead of talking to people about adverse childhood experiences and how that can hurt them in their life, there's actually a website, it's called PACES. PACES stands for Positive and Adverse Childhood Experiences. So what are some of the things that people can do that are protective, that mitigate some of the issues having to do with adverse experiences? Give people, education's empowerment, right? When people know, then they are better able to make informed decisions. So education across the board. This one is really important, to stay vigilant to age-related challenges and changes. And we've talked a lot about what these might be, these different changes and challenges. And I say this because a person may have experienced a lot of losses. You've checked in with them, they seem to be doing good, but something could go wrong tomorrow, and that just kind of is the straw that breaks the camel's back. So we want to check in with people whenever they're experiencing new challenges, and we need to be observant of those because they're not necessarily going to let us know when something has happened that has really put them in a hard place. And then finally, as I've said a couple of times already, that we want to promote hope for health and healing, and letting people know that we believe in them and that we are there for them to help them as they want us to, right? So remember that they need to be in the lead. Let me check what time it is. It's 2:05. I'm going to go through some resources and then I'm going to pull us all together. So here are some things I would recommend for you if you don't already know about Maryland Access Point. It is the Aging and Disability Resource Center in Maryland, and it's not one place. So in all jurisdictions of Maryland, they have what's called an Aging and Disability Resource Service, a resource center, I'm sorry. And they're often called Maryland Access Point. You can Google Maryland Access Point and you can find the resource center in your particular jurisdiction. That's a good way to do it. And this is the website. And when you get this slide deck, you will have an automatic link to this. So anything that an older adult might need to empower them to live independently, this is where you can find that. Assistance with bills and meals and benefits, and let's say they need a grab bar. This is a place where you can call to find that out. If they're looking for senior centers, that's a place to call. The next is Pro Bono Counseling Project, and I mention this because it is such an amazing resource I want everybody to know about for people who are uninsured or underinsured, or maybe they have insurance, but it doesn't quite cover what they need. Recommend that they call the Pro Bono Counseling Project, which uses excellent clinical specialists, therapists across the state of Maryland who have donated their time to help people who are trying to get through some tough times, not necessarily for people who have chronic mental illness and need psychiatric oversight for medication or anything, but definitely for people who are working through some of the challenges that we've talked about today. I like the Sidran Institute for Traumatic Stress Education and Advocacy. I don't know much about their companies, but I do like the resources that they have on their website for people who are experiencing trauma, people who are family members or friends of people who have experienced trauma. And they've also got a nice a set of resources for people who are professionals. I want to let you know about advance directives. So a wonderful way for an older adult to feel empowered is to have them make an advance directive where they can state what their preferences are moving forward in certain circumstances. So if you don't know, there is something called a mental health advance directive. And the link that I've given you is to the information that we have on the website at the Mental Health Association of Maryland. And it's like a packet of information, frequently asked questions, a checklist for things that could go into a mental health advance directive, an explanation of what a mental health advance directive is, how you make one, and what they do. So I really encourage checking that out, especially for people who have had prior hospitalizations for a behavioral health disorder. And Maryland is really pushing for something called supported decision-making. And this is a strategy for people to bring others into their decision-making. They're still in the driver's seat to make their decisions, but they've named some other people that can help support them with education or guidance. It may sound kind of amorphous right now, but it's really interesting and it's emerging as an important first step, especially for people who might be heading towards guardianship. So I would love it if you would check that out. At the Mental Health Association of Maryland, we have a couple of things I recommend that you share with older adults or people who are working with them. And one is this brochure on healthy brain. All of these are free at the Mental Health Association of Maryland. You can go on the website or you can call. I'll give you that information in a minute. Another one is the Mental Health and Later Life Guidebook. This is a beefy one. It's about 90 some pages, and it talks about a multitude of issues having to do with aging and mental health, including things like cognitive impairment, gambling and shopping addictions, caregiving, suicide, all kinds of things that are really important for people to know, again, free. And we have a document that we call our guidebook study group It is a document that tells people how they can start what is like a book club or a book study for the Mental Health in Later Life guidebook. And it's a great way to get older people who may not feel comfortable talking about these topics. If you make it something like a book study where they meet 4, 5, 6 times and carve that book into smaller chunks and then get together and talk about these things, it's obviously wonderful education for them, but we've also seen that it is a good way for organic support groups to start up. So people who have gotten together to read this book together have actually stayed together to provide mutual support. At the Mental Health Association, we also have these great fact sheets. And when you get this slide deck, you will be able to click on any one of these fact sheets and it will give you a link to the fact sheet at the Mental Health Association of Maryland. You can download it, or you can call the Mental Health Association of Maryland and have copies sent to you. All right, so this is free. This is something Mental Health Association does to bring as much education as they possibly can to the community. So I urge you to have these available. Really, if you are working in senior housing or you are part of a community association, and a church, for example, just have this information available, because somebody who's feeling suicidal later in life may not feel or want to talk to you about that. They may feel much more comfortable if they could just pick up this fact sheet because it's sitting in a pile with other resources and other people don't need to know. And it's really, really key information, especially because older adults have very high suicide rates, unfortunately. And now I want to let you know of some of the sources that I consulted in putting this presentation together. I'm happy to talk to groups, any groups, about behavioral health and aging. I try to keep up with the most current data and information. So I welcome you to be in touch with me. I don't have a slide with my personal information, so I'm going to give you that now. Again, I'm Kim Burton with the Mental Health Association of Maryland. Our phone number at the Mental Health Association of Maryland is 443-901-1550. And our website is www.mhamd.org. That's www.mhamd.org. And what I'm going to do now is stop sharing my screen. I can see names, but not necessarily faces. So I wanted to give people an opportunity, if you want to start your video or take yourself off mute and you have any questions. I'm here to talk a little bit more. We've got just a couple of minutes left. Anybody have any questions or feedback? Or, whoa, Marilyn wants to know if I've been vaccinated. Or I haven't been monitoring the chat box. Let me take a look at that. If any of you know resources that you would like to share with each other, I encourage you to do that. All right, well, thank you for coming. I hope this was informational, and I appreciate your attention to this subject. Thank you very much. Take care.